You know that feeling after an injury or maybe surgery? The immediate concern is always healing, right? And often the scar that forms, well, it's seen as just a cosmetic thing, something that'll eventually fade. But for you, as physiotherapists, manual therapists, and movement instructors, we know the impact of scar tissue goes so much deeper than just skin deep. It can fundamentally change how a client moves, their comfort, even their long term health. Today, we're doing a deep dive into scar tissue, specifically looking at it through the lens of your practice. Our mission is pretty clear. We're going to unpack exactly how scar tissue forms, explore its really crucial differences from healthy tissue, and reveal those subtle yet powerful YUGAMI, distortions it can create throughout the entire body. Then we'll explore how targeted, intelligent interventions can make a huge, lasting difference for your clients. Okay, let's jump right in. When most people think about scars, the first thing, like I said, is often appearance, a visible mark. But what are those hidden impacts our clients often face? The ones that go way beyond what we just see on the surface.
Well, what's really fascinating here is how scars, especially the ones we call pathological, like hypertrophic scars and keloids, they're deeply associated with not just, aesthetic concerns, but also significant psychological and social distress for patients. Beyond just what you see, scars can lead to ongoing pain, that persistent itching many patients report, pruritus we call it, and sometimes a really profound loss of movement because of contracture or adhesions. These things don't just exist separately. They directly impact a patient's overall quality of life and their psychological recovery, too.
So, for someone like yourself working hands on with movement and rehab every single day, how do these deeper impacts kind of translate into what you might see? What are some maybe surprising ways scar tissue can cause problems?
Yeah, that raises an incredibly important question. Have you ever considered, for instance, that a client's chronic abdominal pain, or maybe recurrent intestinal obstruction, or even that really persistent lower back pain, could actually be linked to adhesions from, say, a C-section scar? Adhesions are, well, unfortunately, they're an almost inevitable problem after most abdominal surgeries. These are a perfect example of YUGAMI in action. They're like these internal sticky sort of cobwebs. They can bind organs to other tissues, leading to a really surprising range of chronic symptoms and functional limitations, including, believe it or not, in some cases, infertility. It's often not the first thing we connect.
Right. That's where it really hits home, I think. Many patients, they don't initially connect their chronic pain or their mobility restrictions back to their scar tissue. They might come in with what seems like totally unrelated issues, completely unaware of the root cause. And that's exactly why your expertise in identifying and treating these silent distortions, these hidden yugami, is just so vital. Early, targeted intervention can genuinely prevent things getting worse, like progressing to hypertrophy. It can reduce discomfort dramatically and help guide proper long-term care, which can profoundly improve a client's life. It's really about looking beyond the obvious, isn't it?
Absolutely. It's crucial.
So, okay, let's peel back another layer then. How do we actually get these scars in the first place?
Our bodies are pretty amazing at healing, we know that, but it's not always a, perfect return to the original tissue, is it?
Precisely. In us adult mammals, injured tissue is notoriously unable to fully regenerate itself back to its original state. Instead, it gets replaced by what we call dysfunctional fibrotic tissue, basically a scar. This is the endpoint of a very robust but often problematic fibrotic response. The whole process starts with fibroblasts. These are cells normally involved in just creating our healthy tissue structure. But in a wound environment, they undergo this transformation. They activate into specialized cells we call myofibroblasts.
Myofibroblasts. And what makes these cells so unique and, well, so impactful in this whole scarring process?
Myofibroblasts are the real key players in wound contraction. They produce and they aggressively remodel the extracellular matrix, the ECM that's the scaffold of our tissues. Now, in aberrant healing, the kind that leads to problematic scars, what you see is an excessive deposition to connective tissue, mostly collagen. This buildup actually changes the mechanical behavior of the ECM, making it stiffer, and critically, it perpetuates that fibroblast activation, creating this kind of vicious self-reinforcing cycle.
So healthy healing follows certain phases, but scarring is kind of when things veer off that normal course. Could you maybe walk us through those phases briefly and point out where that divergence happens?
Certainly, yeah, normal wound healing goes through pretty distinct phases: inflammatory, proliferative, and then remodeling. The proliferative phase involves forming granulation tissue that's done by those fibroblasts, along with macrophages and new blood vessels growing in. Angiogenesis. It's during the final remodeling phase, which can actually last up to 2 years sometimes. That's when the scar tissue really forms and matures. Ideally, in what we call a normotrophic or a healthy scar, most of those myofibroblasts would undergo programmed cell death apoptosis, they disappear. And the scar would gradually soften and blend in more with the surrounding tissue.
But you called it dysfunctional earlier. What exactly makes scar tissue so fundamentally different from the healthy skin it replaces? Why can't it ever quite get back to that original state?
Yeah, that's the key thing. Scar tissue never fully equals native skin. There are really three main areas where they differ. First, morphologically, meaning its structure, the composition, the organization, even the structural orientation of its ECM proteins are distinct. Scar tissue often has sparse or no hair follicles and less of those unique reapridges you see in healthy skin. Those are the sort of wavy interlocks that anchor the epidermis securely to the dermis, giving skin its pliability and strength. And crucially, the collagen bundles in scar tissue, they're typically arranged in these dense parallel fibers, which contrasts really sharply with the more pliable, strong basket weave pattern you see in normal skin.
Okay, so structurally different. What else?
Physiologically, scar tissue holds only about 70% of its original tensile strength. Even when it's fully mature, it's just inherently weaker. And then biomechanically, how it behaves under force. Healthy skin is naturally viscoelastic. It can deform under stress and then bounce back to its original shape. Scar tissue, though, is significantly stiffer and much less elastic. It has a much greater elastic modulus, lower stress tolerance, and lower failure strain than healthy skin. Just to give you an idea, scarred skin might have a stiffness around, say, 3.0 newtons per millimeter, compared to healthy skin, which is more like 0.75. That's a huge, really tangible difference in how that tissue behaves and feels.
Wow, yeah, that fourfold difference in stiffness and elasticity. That must have a profound impact on movement and overall body function for our clients. So within this spectrum of, let's call it dysfunctional healing, what are the types of scars that tend to lead to the most trouble for them, the ones you really need to watch out for?
Primarily, we distinguish between two main types: hypertrophic scars and keloids. Hypertrophic scars are raised, they're larger than usual, but they generally stay within the boundaries of the original injury site. They're often linked to things like excessive tissue tension during healing, or injuries like burns, and unlike keloids, they can sometimes regress spontaneously, get better on their own over time. Histologically, under the microscope, they contain abnormal amounts of collagen, maybe 5 times higher than normal skin. And it's primarily type 3 collagen arranged in those dense parallel fibers we just talked about, running parallel to the skin surface.
Okay, so hypertrophic stays within the lines, might get better. And keloids, how are they different?
Keloids are, well, they're generally more aggressive. They actually extend beyond the borders of the original wound. They invade the surrounding healthy skin. They don't regress spontaneously, and they're often associated with a genetic predisposition. Sometimes they could even form after really minor injuries, like an insect bite or acne. They have an even higher collagen content, could be up to 20 times higher than normal skin. And it's a disorganized mix of type I and type 3 collagen with these really thick hyalinized bundles, meaning they become dense and glassy because of way too much cross-linking between the collagen fibers. Now, both types contain those alpha-smooth muscle actin-positive myofibroblasts, although in different numbers. And that transforming growth factor beta, or TGFE, pathway is particularly critical here. We think an exaggerated TGFE feedback loop is strongly involved, especially in hypertrophic scars.
Right. So we've covered how scars form, how they're fundamentally different structurally, physiologically, biomechanically. Now, this feels like the really juicy part. How does all of this translate into the actual YUGAMI, this distortion and strain that affects movement, causes pain, and creates these systemic issues throughout the body? How does that happen?
Okay, yeah. Here's where mechanotransduction becomes absolutely central. That's the incredible process where cells convert mechanical cues like tension or pressure into biochemical signals. Mechanical forces you see aren't just a consequence of the scarring, they profoundly drive it. Remember how in normal healing, myofibroblasts do their job contracting the wound and then ideally they disappear through apoptosis? Well, in hypertrophic scars, these myofibroblasts persist, they stick around. And this leads to ongoing unwanted contraction, creating that persistent pulling and distortion we see.
And this persistence, this sort of constant unwanted contraction, you're saying it's actually promoted by continuous tension across the wound itself. So you think about scars over joints or on really mobile skin or areas with high natural tension anyway, like the shoulders, neck, the sternum.
Exactly.
So the very act of moving, the normal tension our bodies experience can, in a way, actually fuel the problem. It can create more YUGAMI over time.
You've hit the nail on the head. Exactly right. The increased stiffness of the ECM itself, that scar tissue, it can activate a positive feedback loop. It triggers more expression of TGF-1, which then promotes the transition of
even more fibroblasts into myofibroblasts. Those new myofibroblasts then produce even more collagen, which further stiffens the ECM. So it creates this relentless cycle of increasing rigidity and distortion. And this is precisely why addressing that mechanical tension is so critical if you want to break that cycle.
Wow. And I assume there are even deeper cellular mechanisms at play here.
Oh, absolutely. We're just scratching the surface. On a deeper level, mechanical stretching, that constant pull, can lead to an exaggerated production of fibronectin. That's a glycoprotein that really accumulates in fibrotic lesions, in scars. And this seems to happen because mechanical stress activates something called the TRPC3 ion channel. This increases calcium influx into the cell, which then triggers activation of a pathway called NF-cover. And that ultimately leads to more fibronectin expression, and you guessed it, further wound contraction.
Now, the cells are literally interpreting the stretch and the tension as a signal to make more of the stiff stuff.
Precisely. They're responding directly to their mechanical environment. And it doesn't stop there. There are also proteins called piezo-1. These are fascinating Caucasian channels that are specifically sensitive to mechanical loading, to being pushed or pulled. In hypertrophic scars, piezo-1 is overexpressed, there's more of it. So when mechanical force from that stiff ECM gets transmitted to piezo-1 on the dermal fibroblasts, it promotes cell proliferation, making more cells, more collagen generation, increased cell motility and contraction.
Yeah.
Basically all the things that exacerbate the scar. Persistent mechanical stress is actively telling the cells, make this scar worse.
That's incredible. And you mentioned another one earlier, FAK.
Right, focal adhesion kinase, or FAK. Now, FAK is crucial for normal wound healing. We need it. But excessive FAK activation is a real hallmark of hypertrophic scars. It acts as another key mechanotransducer, impacting all these intracellular signaling pathways that mediate those fibrotic responses we've been talking about. So yeah, we're talking about a really complex symphony of cellular signals, all responding to and perpetuating this mechanical distortion, this YUGAMI.
This is truly illuminating. It shows how that local, stiff tissue, through these intricate cellular and mechanical pathways, can create systemic YUGAMI, affecting pliability far beyond the scar itself, restricting movement patterns, and subtly altering the entire biomechanics of surrounding healthy tissues. It's this powerful, almost self-perpetuating mechanism that can just ripple throughout the body.
That's a perfect way to put it, ripple effect.
Okay, so given these complex, interwoven mechanisms, it's really abundantly clear why scar management isn't just about, waiting and seeing. It needs active intervention. What kind of interventions have shown real promise, especially those that are right in the wheelhouse for our audience of therapists and instructors?
Well, the good news is that physical scar management, the kind of work you do, demonstrates significant positive effects. That's very clear from the research. Overall, studies consistently show moderate to strong improvements in things like pain, pigmentation, pliability, that itching, pruritus, surface area, and thickness of scar tissue. And your manual therapy techniques are incredibly powerful tools here.
Can you elaborate a bit on how some specific manual techniques actually make that difference at a deeper level?
Absolutely. Take manual manipulations and massage, for instance. These aren't just superficial treatments. These techniques involve specific pulling and stretching forces that mechanically disrupt and help remodel that disorganized scar tissue right down at the cellular level. They directly influence cellular processes by stimulating changes in the expression of ECM proteins and also proteases, the enzymes that break down proteins. And clinical studies have shown really tangible improvements. Scars becoming paler, flatter, more regular in texture, increased stretchability, decreased redness or erythema. High-frequency ultrasounds can even show improved tissue structure beneath the surface. And beyond the aesthetics, massage also significantly reduces pain and improves that crucial pliability.
That makes sense. And what about other widely used methods, maybe less invasive ones, like taping?
Yeah, taping is another excellent modality. Whether you're using kinesiotaping or maybe just simple microporous tape, it works by physically lifting the skin slightly. This can improve local blood and lymph circulation, promote relaxation in the underlying fascia, and reduce edema or swelling. But crucially, taping helps reduce skin tension across the scar line. And remember how important tension is. We know that incisions made parallel to Langer's lines, the natural tension lines of the skin, generally develop thinner, better scars. Taping mimics that tension reduction. It also helps to gently weaken any subcutaneous adhesions that might be forming, which improves the scar's appearance and softness over time.
Yeah. Are there other interventions that come to mind that listeners might incorporate, perhaps ones that need a bit more caution?
Yes. Cupping can be beneficial in some cases. It can promote peripheral blood circulation, potentially improve tissue elasticity, and modify the skin's biomechanical properties. However, and this is important, that should be used with significant caution, really only in the remodeling phase, and generally for older, more mature scars. Applying too much negative pressure or using it too early in the healing process can actually induce microtraumatic injuries and kick off renewed inflammation, which is exactly what we want to avoid. So caution is key there.
Got it. Handle with care. What about needling?
Dry needling is another technique being used. It can help decrease pain and improve scar mobility. The thinking is that it might suppress local inflammation, stimulate reepithelialization, new skin growth, and potentially reduce scar hyperproliferation. For older, more stubborn scars, it might even trigger some regenerative mechanisms inducing new collagen formation, new blood vessel growth, neoangiogenesis, and skin cell proliferation, kind of like kickstarting a healthier remodeling process.
So if I'm understanding this correctly, all these different therapies, massage, taping, cupping, needling, they aren't just about stretching or softening a scar superficially, is that right? They're actually working on those mechanical signals within the tissue itself. They're helping to maybe offload excessive tension or reshape that dysfunctional collagen matrix. Would it be fair to say this directly impacts the activity of those fibroblasts and myofibroblasts we talked about, effectively pushing the healing process towards a more favorable, less fibrotic outcome?
You've captured the core principle perfectly. That is the essence of mechanomodulation in action. We're actively intervening to change the mechanical environment, and the cells, because they're sensitive to mechanics, respond to that change. For example, there are even silicone-based devices like the Embrace system that work by applying sustained tension offloading across a closing wound or a new scar. This has been shown to improve scar appearance and might even help induce apoptosis that programs cell death in those stubborn scar-forming cells. So these interventions are, in a very real sense, guiding the tissue towards a healthier, more functional state by speaking the language the cells understand, the language of mechanical force.
It really does seem to come back to that initial mechanical tension, doesn't it? And how expertly managing it at different stages of healing is just paramount. This is where your expertise, your skill in individualized patient care truly shines, understanding when and how to apply these specific mechanical stimuli for the best effect.
Absolutely. And this understanding leads to perhaps the most important practical question for all of you listening. When is the best time to intervene? We know that early intervention is critical to prevent that scar from fully maturing in a dysfunctional way and to prevent the establishment of those chronic YUGAMI. But the dosage, the intensity, the specific type of manual therapy you choose, it must be precisely adapted to the specific wound healing phase your client is currently in to achieve the most effective, lasting results. It's not one size fits all.
Wow. This deep dive has really truly revealed that scar tissue is so much more complex than just a visible mark on the skin, isn't it? It profoundly impacts function, it causes chronic pain, and it creates these systemic YUGAMI throughout the body through really intricate mechanical and cellular distortions. It's a profound influence on our clients' lives that maybe we sometimes overlook or underestimate.
Indeed. And understanding these unique biomechanical properties of scar tissue, understanding the persistent activity of those myofibroblasts, and knowing about those detailed mechanotransduction pathways we explored today, PDOS-O, OFF-AK, TGF-beta, it really empowers you as therapists and movement instructors to make incredibly informed and impactful treatment decisions that go far beyond just treating the symptoms.
Yeah. As physiotherapists, manual therapists, movement instructors, you are uniquely positioned to intervene early to mitigate these distortions and significantly improve your client's quality of life, restoring function, and alleviating chronic pain that might have otherwise seemed completely unsolvable or unconnected.
So perhaps for your next step, maybe consider this. How can your precise application of mechanical stimuli, whether that's through your hands and massage or using tape, or maybe incorporating other modalities like needling or even guiding specific movements, how can that continue to unlock even greater regenerative potential? How can you help restore holistic function for those living with scars and potentially change their long-term health trajectory in a really profound way?
Yeah.